So the lens-associated glaucomas covers a lot of ground, and we're going to talk about phacolytic, phacomorphic, lens particle, phacoanagenic, ectopia lentis, and spherophakia. Phacolytic glaucoma is a loss of high molecular weight protein through a grossly intact lens capsule. So grossly intact is sort of the buzzword. There's no break in the capsule that is visible to you. But it appears that the protein leaks through microscopic openings in the stretch capsule. This always occurs in the setting of a long-standing cataract. So you never see this in somebody who's 40 last month and now comes in with phacolytic. The more common situation is that someone has a cataract removed from one eye, feels that they're doing fine and lets the other eye go, or else someone who doesn't have access to medical care. But it's always a long-standing cataract and poor vision for a very long time. They present with very high intraocular pressure, corneal edema, conjunctival injection, and pain. On exam, you see macrophages in the anterior chamber. So these are bigger than cells, and there's no chorotic precipitate. So you have this marked reaction in the anterior chamber, but not KP. One can even have a pseudohypopion from all of this stuff settling to the bottom. And again, there's a dense cataract, often a Morgagnian cataract, which means that the lens nucleus has sunk in a sea of liquefied cortex. So this is a classic appearance of somebody with phacolytic glaucoma. You can see that her left eye is pseudophakic. The right eye has a Morgagnian cataract. You can see the upper edge of her lens nucleus here, where it is settled down in liquefied cortex. Closer view of a Morgagnian cataract. And just a great video. Again, here you can see a Morgagnian cataract. You'll see the nucleus in here as we go along. But look at how large these cell-like bodies are floating around in the anterior chamber. It looks like cell, but cells aren't that big. So this dense cataract, Morgagnian cataract, macrophages in the anterior chamber makes a diagnosis of phacolytic. Rarely you can see somebody who has ectopia lentis where the lens is in the vitreous and the lens can be there for decades and then become phacolytic. As you see in this picture, and you can see this big round lens on ultrasonography with inflammation streaming from it. So you treat this with aqueous suppressants, but the definitive treatment is a removal of the cataract, and that is not easy because the lens is very, very stretched, the cortex is liquefied, and the nucleus is very hard. This is just a brief clip from Tim Johnson, one of my partners, just showing that this milky cortex spewing forth through a very tiny break in the anterior capsule, but prior to doing a full capsulorhexis, you can see that every time he stops suctioning, more and more of this milky fluid comes forward. Also remember that the lens capsule is under tremendous stretch and it's very easy to perforate or tear the capsule, and you can get what's called the Argentinian flag sign. And this is from another one of my partners, Tom Oding, and basically this is a lens that has been stained with trypan blue, and as soon as the capsulorhexis was begun, this huge rent occurred across the entire anterior surface of the lens capsule. And so the white band in the blue field is called the Argentinian flag sign because it looks just like the Argentinian flag. Phacomorphic glaucoma just means that the lens is too big. So you have a large lens, usually in a small eye. It can be in a normal-sized eye. This can lead to pupillary block, or the lens itself can become so large that it can collapse the angle by its sheer volume. This is a phacomorphic eye. This eye is small, 21.2 millimeters long, and the lens is immense, 5.1 millimeters thick. Just a brief video of an eye with phacomorphic changes. You can see that the anterior chamber is very narrow. You sort of get the sense that the iris is draped over a very big lens. And you can actually see ciliary processes in there which you normally cannot see, which just means that the lens is very far forward, very thick. So you might see that same thing in a lens that is dislocated forward that allows you to see the ciliary processes, and we'll see that in a few minutes. You can do an iridotomy, and that's certainly what I would do to relieve the pupillary block component, and sometimes that's all you need to do. But if the angle remains narrow, then I would do biometry, measure how big the eye is, how thick the lens is, and then the definitive therapy is to remove the lens and replace it with an intraocular lens, which is much, much thinner than the crystalline lens. Remember that cholinergic agonists, which we don't use much for anything anymore, can worsen this by moving the lens iris diaphragm forward. Lens particle glaucoma, in my experience, is less common than the prior two. One can have a broken capsule and release of cortical particles that clog the meshwork. This can happen after cataract surgery, but there are so many other things that can cause pressure to go up after cataract surgery. It's a little hard to sort out lens particle. You can see this after capsulotomy or after trauma. You'll notice an elevated intraocular pressure and then cortical material in the anterior chamber, a moderate anterior chamber reaction, and if left untreated, all of this cortical material can lead to synechia, both peripheral anterior synechia and central posterior synechia. This is a traumatic example. This is someone who was hit with a pool cue. You can see in the left side of this slide that they have a break in their sphincter, just meaning that they've had trauma. And you can see these shining little pieces of lens cortical material in the angle. And on AC tap, we could find part of the cortex. More commonly, I think you'd see this after cataract surgery where someone didn't do an adequate job of cleaning out the cortical material and it fluffs up and comes forward. Again, we treat this with aqueous suppressants. One would use corticosteroids and may need to go in and surgically remove the cortical material. Phacoanagenic used to be called phacoanaphylaxis, but it really is not an anaphylactic response. In my experience, this is really rare as a cause of glaucoma. The patient becomes sensitized to their own lens proteins. They usually have low pressures in their eyes. They generally don't come in with glaucoma. The eyes are very sick. You can see this eye, you can suture there, indicating that they've had trauma, hypopyon, thick cornea, really unhappy eye. They can have keratotic precipitates because they have this granulomatous response. And on histopathology, they have this zonal inflammation around retained lens material. We treat these patients with corticosteroids. Again, aqueous suppressants, that's virtually never the wrong answer. They may need to have removal of residual lens material. And there is some increased risk of sympathetic ophthalmia in the fellow eye as these eyes are sensitized to lens protein. Ectopia lentis just means that the lens is dislocated, is displaced from its usual position, and that can cause pupillary block. Or if the lens is completely dislocated into the vitreous face can prolapse and cause pupillary block. And as I mentioned early in this talk, a lens dislocated into the vitreous can cause phacolytic glaucoma, although that's pretty uncommon. This is just a picture of a patient with ectopia lentis. The lens displaced superiorly here, just a few little zonules hanging on for dear life. Again, as I mentioned, under phacomorphic, as the lens comes forward on gonioscopy, it gives you the opportunity to see the ciliary processes, which you should not see in a normal eye. This is someone whose lens is dislocated into the anterior chamber. Obviously, you need to get the lens out of the anterior chamber. It's tough on the corneal endothelium. It can also cause pupillary block. Some people would dilate this eye and let the lens fall into the vitreous. I think the best course would be to remove the lens, and that would require an intracapsular cataract extraction, making a very large incision and just sliding this lens out as in one piece. It's critical, though, prior to going to the operating room, that the patient is given a cholinergic like pilocarpine, because if one gives the patient a block and the patient's eye dilates and the lens tumbles into the vitreous, that would make the surgery much, much more challenging. Just a picture of a lens, clear lens, in the vitreous, and one does not necessarily need to go after this lens. It can be left there as long as it's not bothering the patient. And this is a slide I showed earlier, just showing phacolytic changes in a lens that has been in the eye for many, many years. There are a lot of things that can cause this. Number one, in elderly patients is exfoliation syndrome. And number one in younger patients is trauma. But there's a long list. Simple ectopia lentis, eyes that are big enough from bupophthalmos, the zonules can stretch and break. Marfan syndrome often has ectopia lentis. Spherophakia, like in Weill-Marchesani syndrome, and some other systemic diseases like homocystinuria, hyperlysinemia. There are long lists, but I think these are the major ones. There is an uncommon condition called ectopia lentis et pupillae, in which the lens and the pupil go in opposite directions. So in this patient, the pupil is going up and out and the lens is going down and in. This is an autosomal recessive condition and is quite uncommon. One can do 2 iridotomies 180 degrees apart, with the thought being that if the lens covers the pupil in one iridotomy, there should be one that is open, or a lensectomy. And most of my patients I have treated with a lensectomy, either from the front or have one of my retina colleagues do a pars plana vitrectomy lensectomy. Remember that if the lens is loose, cholinergic agonists can increase the pupillary block. Spherophakia, sometimes also called microspherophakia, is a condition where the lens is very round, and that can cause pupillary block. And this is a unique condition in which somebody has angle closure glaucoma, pupillary block angle closure glaucoma, in the setting of high myopia. So if you see somebody with pupillary block and they're -10 myope, then they have spherophakia until proven otherwise. It can be associated with systemic disease called Weill-Marchesani syndrome, in which people tend to have short, stubby fingers. They tend to be sort of the opposite of Marfan syndrome, small stature, short fingers. Just a slit lamp picture of spherophakia, and what I'm trying to show here is just how round this lens is in this slit beam, almost perfectly round. And on gonioscopy, you can see the lens pooching through the pupil here, which you never see with a normal lens. And on dilated examination, you can actually see the edge of the lens. It sort of looks like this is someone wearing a hard contact lens, but this is their crystalline lens. It's so small and round that when the pupil's dilated, you can see the edge of it. Like all of these diseases, you want to avoid cholinergic agonists. You would do an iridotomy for the pupillary block component. So let me just go through all these again. There's kind of a lot of material here. Phacolytic, long-standing cataract, leakage of protein through a grossly intact lens capsule. Again, grossly intact. They have macrophages in the anterior chamber. There's evidence that the high molecular weight protein by itself can cause the obstruction of outflow. They don't have keratoc precipitates, and you treat them by removing the lens, which is challenging. Phacomorphic is a big lens and a small eye. They have some element of pupillary block, but the big lens by itself can physically close the angle with the volume of the lens. Iridotomy may help. It certainly would get rid of the pupillary block component, but they may need to have their lens removed. Lens particle, less common. You have cortical material that clogs the angle, treated with steroids and aqueous suppressants, and one may need to go in and remove the offending cortical material. Phacoanagenic is a rare condition with a broken lens capsule and a granulomatous response to the lens material, a zonal inflammation surrounding the lens material on histopathology. These patients are treated with steroids. These are really sick eyes, and they may need to have surgery to remove the lens material. Ectopia lentis, lots of causes, but trauma and exfoliation syndrome are the highest on the list. They can cause pupillary block. If it's dislocated into the vitreous, rarely it can cause phacolytic, although that may be decades later. One can do 2 iridotomies to prevent the pupillary block or remove the lens. And lastly, spherophakia, a round lens. Always think of this in a patient with pupillary block who has high myopia. You can perform an iridotomy to break the pupillary block, and it's associated with Weill-Marchesani syndrome. So quite a lot of material, but these are, I think, interesting diseases, all of them, and most of them are things that you'll see in your career.